Thank you, Dr. Nisha, for this lucid presentation. And all the graphs were explained very beautifully. And I hope everyone has seen the graphs carefully, as these are important from examination point of view. And are there any questions?
No, ma'am, there are no questions as such right now.
Okay.
We can move to the next presentation, and then in the end, we can see if there are any more questions.
Okay, fine. So next topic to be covered is breathing circuits and their clinical implications. I call upon Dr. Vandana Arora from PGI MS Rohtak for this presentation. Over to Dr. Vandana.
Hey everyone. So today we will be discussing about breathing circuits and their clinical implications. These are very important from your exam point of view, as in your Viva, you can be asked about the identification and the function analysis of the circuit. Also, you can get a theory question regarding the functional analysis of the circuits. So we'll be discussing about definition, components of breathing systems, their classification, and we will be discussing in details the Mapleson systems and a few things about the closed circuit. So what is the definition of a breathing circuit? It is a gas pathway or an assembly of components which connects the patient's airway to the anesthetic machine for to and fro delivery of a controlled gas mixture at physiological pressures. What are its functions? You have to deliver a controlled composition of a gas mixture. You want the carbon dioxide to be eliminated. A circuit should be able to support spontaneous as well as controlled ventilation. You need to conserve heat and humidity of the air you are breathing. Gas sampling should be possible, and there should be conversion of plenum to intermittent flow. So the criteria for an ideal circuit, again, it should fulfill all the functions of the breathing circuit, as well as it should have a minimal dead space and resistance. It should be economical, convenient to use, and easy to sterilize. So first we'll discuss a few terms before we start discussing the circuits. So what is rebreathing? It is the inhalation of the previously expired gases from which carbon dioxide may or may not have been removed. What are the factors influencing this rebreathing? Fresh gas flow, mechanical dead space, and the design of the breathing system. So rebreathing is not entirely bad, as it maintains economy as well as it retains heat and moisture. But it is bad for as it will decrease the inspired concentration of oxygen. With inhalational agents, it will delay the induction as well as the recovery. What happens during induction is the concentration of the anesthetic agent in the rebreathed alveolar gases will be lower as compared to the fresh gas flow. So it will decrease the concentration of the anesthetic agent in the fresh gas flow and will delay the induction. While during recovery, the concentration of the anesthetic agent in the rebreathed alveolar gases will be high as compared to the fresh gas flow, which will be added to the fresh gas flow, and it will slow the elimination of the agent. Rebreathing will lead to an increase in FiCO2. Coming to the mechanical dead space. What is dead space? It is the volume occupied by the gases that are rebreathed without any change in composition. How can we minimize it? By separating our inspiratory and expiratory gas streams as close to the patient as possible. Now the components of the breathing circuit, we will discuss them one by one. The reservoir bag. As you have seen, the commonly used size is 2 liters. It is available in other sizes also, pediatric size, and it is formed from synthetic latex rubber. See, this is the bag. This is the neck of the bag with a 22 mm female connector, and this is the tail end of the bag. This is a pediatric size bag with an open tail end. What are its functions? So, it will allow you to collect the fresh gas during expiration. So it will decrease the amount of the fresh gas flow which is required to prevent the rebreathing. You can use this bag for manually ventilating the patient in cases of assisted or controlled ventilation. Bag also serves as a visual and tactile monitoring device for spontaneous respiration. Breathing tubes are large bore corrugated plastic tubes which provide a flexible, low resistance and lightweight connection from one part of the system to the other. So these are the corrugated tube, and these corrugations increase the flexibility. The materials used may be silicone rubber or polyethylene hose. These are available for adults as well as pediatric patients in different sizes. And at the ends, there are smooth walls where tapered connectors can fit into these tubes. Now, these tapered connectors or adapters, these provide a way to join those rigid tubes or one part of the system to the other. So these have a female half and a male half. These are various connectors. You can have a right angle connector with a gas sampling port, or a straight connector, or a Y connector. So what is the use of these connectors? It will extend the distance between the patient and the breathing system. It can change the angle of connection, as well as it allows for a more flexible connection. Disadvantage is that these connectors will increase the resistance and dead space, and there will be more number of locations at which disconnections can occur in your circuit. Now the APL valve, which is also known as pressure relief valve or pop-off valve. The purpose is to allow the escape of the expired gases, and the pressure required to open the valve is very low, that is to minimize the resistance to your expiration. These are the pictures showing the APL valve. We won't go into much details on this. Then the filters which we're using commonly nowadays, these protect the patient from microorganisms and airborne particulate matter, and also help to increase the humidity. These are the pictures of filters. These may be mechanical or electrostatic filters. What are the problems associated with filters? Again, they'll increase the dead space as well as resistance. So they will be problematic with spontaneous respiration, or they can get obstructed, or leaks can occur if there is a defect in the filter. Coming to the classification of the breathing circuits, there are various functional classifications of the circuits. First one is Drips, Eckenhoff, and Vandam classification. These classified the breathing systems into 5 categories based on the presence or absence of these 3 things, that is reservoir bag, rebreathing, and CO2 absorbent. The 5 systems are insufflation, open, semi-open, semi-closed, and closed. In insufflation, the gases are delivered directly. There are no valves, no bag, or no CO2 absorbent. In the open system, valves are present. There is minimal rebreathing, and reservoir bag is optional. Semi-open, valves and reservoir both are optional, and rebreathing entirely depends on the fresh gas flow, and there is no CO2 absorbent present. In semi-closed system, all the things are present with partial rebreathing, while in closed system, all things are present and there is complete rebreathing of the expired gases. Next, in the Collins classification, they divided these breathing circuits into 4 categories, that is open, semi-open, semi-closed, and closed, based on whether the inspired and expired gases are open or closed to the atmosphere, and whether the reservoir is present or absent. Then there is McMahon classification. Depending on the rebreathing, they divided the circuits into open where there is no rebreathing, semi-closed where there is partial, and closed where there is total rebreathing of the expired gases. Next is the Miller's classification. First, they divided the systems depending on the presence of CO2 absorbent, and then further classified them depending on the direction of flow, whether it is unidirectional or bidirectional. So our Mapleson systems comes in the classification of bidirectional flow without CO2 absorbent, while the circle system with unidirectional flow with CO2 absorbent. Then there are some other classifications also. These you can read and remember. So we can broadly divide our breathing systems into open, semi-open, semi-closed, and closed, depending upon these things: reservoir bag, rebreathing present or absent, presence or absence of CO2 absorber, unidirectional valves, and fresh gas flow rate. So the open systems consist of insufflation and open drop methods. Are all Mapleson systems comes in the semi-open, and circle system can be semi-closed or closed. This is a picture showing the insufflation system. Then there is an open drop system, which consists of a mask known as the Schimmelbusch, and agents used are ether and chloroform. These will be discussed in detail, I think, in your class on ventilators. Now we'll be discussing the Mapleson breathing circuits. Described by Professor W. Mapleson, these are divided into categories depending upon the presence or absence of fresh gas entry, APL valve and reservoir bag, and their relative position to the patient end. These all are semi-open circuit systems, and these are classified as A, B, C, D, E, and F, depending upon the position of fresh gas, APL valve, and the reservoir bag relative to the patient end. Now the Mapleson A. The classic form, APL valve, as you can see, is near the patient end. Fresh gas flow is away from the patient. Reservoir bag is in between, but away from the APL valve and close to the fresh gas flow. There is a corrugated tubing which separates the bag and the valve. So here is a functioning Mapleson A circuit. Then comes the lac modification of Mapleson A. Here there is an extra expiratory limb with an APL valve at the other end, and it has two arrangements. It can be coaxial with expiratory limb inside the inspiratory limb, or it can be a parallel arrangement with two tubes parallel to each other. Now, how to use this Mapleson circuit? For spontaneous ventilation, APL valve is left in the fully open position so that the gases are vented during expiration. While for controlled ventilation, APL valve is partially closed and the gases are vented out during inspiration. Functional analysis of Mapleson A. First, we'll discuss the spontaneous respiration. So what happens during expiration is, first, the dead space gases and then the alveolar gases flow into the corrugated tubing towards the bag, and at the same time fresh gas flow is flowing into the bag. When the bag is full, pressure increases, the APL valve opens, and the first gas vented out will be the alveolar gases. Now, depending on the fresh gas flow, the other gases will be vented out. If the fresh gas flow is high, then dead space gases will also be vented out. If it is intermediate, then some dead space gases are going to be retained. While if the fresh gas flow is low, there will be rebreathing of alveolar gases also. What happens in inspiration is, first gas inhaled will be the dead space gas. Next gas to be inhaled again depends upon your fresh gas flow. If it is high, then the dead space gases will be vented out and the patient will breathe the fresh gas. While if it is intermediate, some dead space gases which were retained are going to be breathed by the patient. While if the fresh gas flow is low, then alveolar gases are going to be rebreathed by the patient. Now, the controlled ventilation with Mapleson A. Again, during exhalation, all gases which are exhaled by the patient, they remain in the corrugated tubing, and the alveolar gas will be near to the patient. So, during inspiration, when the bag is compressed, the alveolar gases which are nearest to the patient will be inhaled first. So, and as the pressure increases, gases will be vented out. The alveolar gases, the dead space gases, along with the fresh gas flow will go to the patient, as well as they will be vented out through the APL valve. So, Mapleson A is not good for controlled ventilation. These are the fresh gas flow requirements for Mapleson A circuit for spontaneous and controlled ventilation. For spontaneous ventilation, fresh gas flow required is 51 to 85 ml per kg per minute. While for controlled ventilation, it is very high and difficult to predict. Therefore, it is not recommended for controlled ventilation. Now, how to check your Mapleson A circuit before use? You need to test it for leaks. What you do is you occlude the patient end of the system, close the APL valve, and you pressurize the system. If the pressure is maintained, it confirms the integrity of your circuit. For coaxial LAC system, additional testing is required as you need to confirm the integrity of the inner tube. So the first test, what you do is you attach an endotracheal tube to the inner tubing at the patient end. Your APL valve is closed. and blowing through the endotracheal tube will produce movement of the bag if there is any leak between the two limbs. The second test is, what you do is you occlude both the limbs at the patient end and then squeeze your bag with APL valve open. If there is any leak in the inner limb, the gas will escape through the valve and the bag will collapse. So the advantages of Mapulson A circuit, that it is ideal for spontaneous respiration, economical, easy to assemble, manage and maintain. Disadvantage, it is not recommended for controlled ventilation. Mask ventilation will be uncomfortable. It limits your mobility, and the APL valve being close to the patient, there will be difficulty in access as well as scavenging the gases. Coming to Mapulson B. Now here the fresh gas flow as well as APL valve are close to the patient port. The reservoir bag is separated from the fresh gas inlet by a corrugated tubing. Functional analysis of Mapulson B. For spontaneous respiration, as the patient exhales, dead space gas will pass down the corrugated tubing along with fresh gas and some alveolar gas. When bag reaches your full capacity, the APL valve will open and both the fresh gas and the alveolar gas will exit from the system. When the patient begins to inspire, pressure will decrease and APL valve will close and the patient inhales the fresh gas and the other gases from the tubings. No gas will be inhaled from the bag if the volume of the tubing exceeds the tidal volume. So to avoid rebreathing, fresh gas flow needs to be equal to your peak inspiratory flow rate or more than 2 times your minute volume. For controlled or assisted ventilation, functional analysis of Mapulson B is similar to Mapulson A. However, it is slightly more efficient as fresh gas accumulates at patient end during the expiratory pause rather than at the machine end. And the fresh gas flow required for controlled ventilation in Mapulson B is 2 to 2.5 times the minute volume. Mapulson C system is identical to your Mapulson B except that there is no corrugated tubing separating the valve and the bag. Functional analysis of Mapulson C is similar to your Mapulson B. For spontaneous respiration, Mapulson C is as efficient as Mapulson A but with minimal expiratory pause, and these are the fresh gas flows required for spontaneous and controlled ventilation with Mapulson C. Now these Mapulson B and C system are not commonly used in anesthetic practice. C system may be used for emergency resuscitation. Now the Mapulson D system, the classic form. The fresh gas flow is closest to the patient, while the reservoir bag is far away from the patient. APL valve is between the bag and the fresh gas flow, but it is close to the bag, and there is a corrugated tubing between the valve and the fresh gas flow. This is a classic Mapulson D circuit, and this is the Bain modification of the Mapulson D circuit, which is a coaxial circuit with inspiratory tube running in between the outer expiratory tube, and the fresh gas flow flows through the inner tubing. So this is again the Bain modification showing the inner inspiratory tube for the fresh gas flow, and there is an outer transparent expiratory tube. Now, how to use this Mapulson D circuit? For spontaneous respiration, again, APL valve left fully open like Mapulson A, and excess gases are vented during expiration. While for controlled ventilation, APL valve is partially closed and excess gases are vented during inspiration. Coming to the functional analysis of Mapulson D circuit, first we will discuss the spontaneous respiration. Now, what happens during expiration is that exhaled gases, they mix with the fresh gas and move to the bag. After the bag is filled with gas, it exits through the APL valve from here. During the expiratory pause, the fresh gas will push the exhaled gases down in the corrugated tubing towards the APL valve. And during inspiration, the patient will inhale from both the tubes, that is the outer as well as the inner tubing. Now the inhaled gases depends on the amount of fresh gas flow. If fresh gas flow is high, only fresh gas is inhaled, while if fresh gas flow is low, some expired alveolar gases will be rebreathed by the patient. Now for controlled ventilation, what happens during exhalation is exhaled gases flow from the patient down the corrugated tubing and same time fresh gas enters the tubing. During expiratory pause, the fresh gas will push the exhaled gases down the corrugated tubing. During inspiration, we compress the bag, pressure increases, fresh gas and gas from the corrugated tubing will enter the patient and APL valve will open to vent out the exhaled alveolar gases. Now, rebreathing in a Bain circuit can be decreased by adding a long expiratory pause, by increasing Is to E ratio, and by a slow rise in inspiratory flow rate. By all these things, increasing the respiratory rate, increasing inspiratory time, and inspiratory plateau is going to increase rebreathing. Fresh gas flow required for Mapulson D circuit and for spontaneous respiration is 100 to 300 ml per kg per minute, or 1.5 to 3 times the minute volume. While for controlled ventilation, 1 to 2 times the minute volume is sufficient. How to check your Mapulson D system? You can check the leak by occluding the patient end of the system, closing the APL valve, pressurizing the system, and again, if the pressure is maintained, then there is no leak in your system. For Bain modification, you need to check the integrity of the inner tube. So what you can do is, you can set a low flow on oxygen flow meter, occlude the inner tube with your finger or with a syringe, then observe the indicator on the flow meter. If the inner tube is intact and it is correctly connected, the indicator will fall. The other test which you can do is, you close your APL valve, activate the oxygen flush and observe the bag. Due to the Venturi effect, bag will deflate if your inner tube is intact. So what are the advantages of your Bain circuit? It is lightweight, there is minimal drag on your endotracheal tube compared to Magill circuit. It has very low resistance, that is less than 0.7 centimeters water. Your outer tube is transparent, so you can detect any kinking or disconnections of the inner tube. It can be used for both spontaneous and controlled ventilation. And it is easy to connect to a ventilator. Disadvantages: there is a risk of disconnections, wrong assembling of the circuit can lead to malfunction, theater pollution can occur due to high fresh gas flows. There is increased cost, kinking in the inner tube can lead to hypoxia, it cannot be used for pediatric patients, and cracks in inner tube can lead to leakage. Now the Mapulson E system. It is a simple T-piece with 3 open ports. There is no reservoir bag and no APL valve. How to use it? For spontaneous ventilation, the expiratory limb is open to the atmosphere and the patient breathes in and out. For controlled ventilation, it can be performed by intermittently occluding the expiratory limb and allowing the fresh gas flow to inflate the lungs. Functional analysis is same like Mapulson D. Length of the expiratory limb of Mapulson E circuit will determine rebreathing. If it is too long, then rebreathing can occur. However, if it is too short, air dilution can occur as the patient will entrain air from the atmosphere. Hazards of Mapulson E include overinflation and barotrauma, as by intermittently occluding the expiratory limb, this can occur. How can you prevent air dilution in Mapulson E? If the volume of your expiratory limb is more than the patient's tidal volume, fresh gas flow more than peak inspiratory flow rate or 3 to 5 times the minute volume, fresh gas flow equal to 2 times the minute volume but with expiratory reservoir of 1/3 of the tidal volume of the patient, and it will not occur in controlled ventilation. The expiratory part of Mapulson E may be enclosed in a chamber from which the gases are evacuated. There is difficulty in scavenging these excess gases, that is why the use is decreased. Now the Mapulson F system. It is a Jackson-Rees modification of the IST piece. Here, after the corrugated tubing, there is a bag attached with an open tail end. Here you can see the JR circuit and the pediatric bag with the open tail end. You must be using it in all your pediatric patients. How to use it? For spontaneous respiration, relief mechanism, that is the tail end of the bag is left fully open. For controlled ventilation, the relief mechanism is occluded sufficiently to distend the bag, like you use your fingers to occlude the bag intermittently for controlled ventilation of the patient. So what are the advantages? Very low resistance and dead space. It is very compact, easy to use. It is very economical, inexpensive. And there is a visual monitoring of volume and respiratory rate, which you cannot see in Mepulsin E. And addition of CPAP and PEEP is possible in Mepulsin F, which is not possible in Mepulsin E. So for your spontaneous ventilation, Mepulsin A is the best system, while for controlled ventilation, Mepulsin D is the best system. And to summarize, these are the various fresh gas flows required for spontaneous and controlled ventilation in the various Mepulsin circuits. Now, just a brush up about the circle system. Why is it called a circle system? Because gases flow in a circular pathway through separate inspiratory and expiratory channels. Carbon dioxide exhaled by the patient is removed by an absorbent. What are the essential components? There is a soda lime canister in which CO2 absorbent is stored, as there is rebreathing of the gases. So CO2 is absorbed by this CO2 absorbent and the gases are rebreathed by the patient. Fresh gas inlet is there. There are unidirectional valves in the inspiratory and the expiratory tube for unidirectional flow of gases. There is a reservoir bag, there is an APL valve, and there is a Y piece at the patient end. So advantages are, it is very economical, there is very low pollution, you have carbon dioxide free inspired gases, and it conserves the heat and humidity. Disadvantages, very high resistance, sterilization is difficult, there is a risk of compound A formation, and if the soda lime gets exhausted, then hypercarbia can occur, and there is a risk of infection. So this is a picture of the circle system showing the flow of gases from the fresh gas inlet. The gases enter the inspiratory limb. Here is a unidirectional inhalational check valve. The gases flow through the inspiratory limb to the patient through the Y piece, and the gases expired by the patient flow through the expiratory limb. There is an exhalation unidirectional valve. These expired gases flow through the CO2 canister where there is CO2 absorbent and the CO2 is absorbed. So again, the gases flow into the inspiratory limb and these combine with the fresh gas flow and these gases are again inhaled by the patient. There is a bag or ventilator select switch here by which you can either switch on to the manual ventilation where you can use the APL valve or you can switch on to the ventilator. Hope you guys had a good revision of your circuits. All the best to all of you.
Thanks, Dr. Vandana, for a nice and well-balanced presentation. I just want to emphasize that three circuits, mainly Bain circuit, then Jackson-Rees ISTPs, and closed circuit, they all are still used clinically and everyone should have a good knowledge of these. Now, do we have any questions?
No, ma'am, there are no questions.
Okay. So is there any mechanism that if somebody wants to ask questions later on?
Ma'am, in case we receive the questions later, we can just direct it to the speaker.
Yeah, I think they
that's
can
good.
mail it to us. You can mail it to us maybe. If there are any questions later on, you can mail it to us and we'll reply.
No problem.
That
We
will be
can do
nice.
that. Yeah, we can do that.
Because somebody may have a retrospective
Yeah, sure.
question. Right? Yeah, thank you.
Thank you. Thanks to the organizers and thank you, ma'am.
Thanks. Nice presentation.
Thank you, ma'am.
Thanks to the organizers.
Thank you, ma'am.
Yeah.
Thank you to the speakers. Well presented. So we'll quickly have our first quiz for the day before we start with the long case discussion. Can we have the questions for the quiz? The delegates are required to answer them at the earliest as fast as possible. Which of the following, the first question is, which of the following is not a method for measuring the residual volume and the functional residual capacity? A, CO2 absorption test. B, nitrogen washout technique. C, helium dilution method. Or D, body plethysmography. Moving on to the next question. What are the wavelengths of red and infrared light used in a pulse oximeter? Option A is 660 and 940 nanometer. Option B is 620 to 980 nanometer. C is 600 and 950 nanometer. And D, sorry, there's I think an error. The last is the D option, which is 650 to 940 and 940. So moving on to our next session, which is a long case presentation of a 55-year-old male who's a known case of COPD and is posted for laparoscopic incisional hernia. And I would like to invite a very eminent faculty as an external examiner, Dr. Sonia Badawan ma'am. She is Director Professor at the Department of Anesthesia and Critical Care at Maulana Azad Medical College, New Delhi. Ma'am has several publications in national and international journals, is an ACLS provider and instructor, and is actively involved in the training courses. She's the founder member of Airway Management Foundation. She's faculty in airway workshops and PG assemblies and in various national conferences. She's a postgraduate examiner with various universities and is a member of ISA, IPA, ICA, RSAPCON, and Obstetric Society. And ma'am's area of keen interest are airway, obstetric, and pediatric anesthesia. We welcome you, ma'am.
Good morning, Dr.
Morning, ma'am.
Good morning, Nitin. And at the outset, I would like to thank all the organizers, Dr. Mohandeep, for giving me this opportunity to be a part of the PG Assembly. And I look forward to this case discussion on COPD, which is a very, very common case scenario in our Indian setup. And there are so many surgeries which are done for incidental surgeries in a patient with COPD. So without wasting any further time, I'd